regular exercise has been shown to have the same magnitude to decrease risk as a single copy of ApoE4 has to increase risk. So you literally can negate the risk of one copy of ApoE4 through regular exercise.
Dale, welcome back. It is so good to have you here today. I'm excited. Your new book, The Ageless Brain, is, wow, it's an incredible resource. I was looking at the back of it earlier and just the number of like tests and ranges of things that people can look at. Like, you really are putting power back into the hands of the individual with this book. I think it's phenomenal. Welcome. I'm so happy to have you here today.
Great to be back. Thank you so much, Angela.
Yeah, I just think your work is so, so important. And I know that not just on the podcast, but if ever we post anything that is vaguely brain related on Instagram, it gets so much traction. And I think women, a lot of my audience are women sort of in the similar age bracket to myself, are acutely aware of the risks and really, really want to maintain their cognitive health. I've heard you say that Alzheimer's is optional. We don't have to get it, even though so many of us do. Can you explain a bit more about that?
Yeah, this is a great point. And of course, as you can imagine, a controversial one. People will say, what do you mean? But so here's the thing. The number one cause of death in the women in the UK today is Alzheimer-related dementia. So it's incredibly common. 45 million Americans will die of Alzheimer's disease, statistically, of the currently living Americans. So it is an area where we all need to focus because there has been so little treatment for it. However, we understand the underlying processes like never before. And we now are in our second trial. We already published a successful trial, a proof of concept trial a couple of years ago, and we're now in the middle of a randomized controlled trial. We have interim analysis at the halfway point, and it's strikingly successful in that we see people who are being treated with a precision medicine approach, where you're looking at each thing that is driving this. They are doing this, they're improving, whereas people who are being treated with standard of care, no surprise, are declining, just as we've seen over the years. So what's happened is that in the past, and still in many centers, they're trying to look at this as a disease where you have a misfolded protein, or, quote, something went wrong. It's a pathological description. Why did you have this? A protein misfolded. You made amyloid for some reason. You made phospho-tau for some reason. This is an outdated view of what's actually causing the problem. What we discovered in 30 years in the laboratory is that you need to look at this physiologically. This is a response, just as your immune system is a response. In other words, there's some analogy to multiple sclerosis. When you get multiple sclerosis, you have been exposed typically to a virus, and it's typically the Epstein-Barr virus, although there seem to be others as well, but that's the one that's been revealed as the dominant one. Your body is responding as it should, but when it responds to the Epstein-Barr virus, you get an autoimmune disease because it's also responding to parts of your own brain, so that you're getting these demyelinating lesions. You're losing your myelin, the coating. Now, in Alzheimer's, what's happening is you're getting exposed to all sorts of different things. It's various pathogens, things like herpes simplex. And Professor Ruth Itzhaki from the UK has spent her career showing this intimate relationship between exposure to herpes simplex and the development of Alzheimer's disease. But that's just one of many factors. It's oral bacteria like P. gingivalis. It's leaky gut, for example, chronic sinusitis, exposure to various toxins. Now, what happens when you get this is very interesting. You produce this amyloid, which is a response to these various insults. And what this does is, it's a little bit like putting an insect in amber. You're coating this with something that isolates it and destroys it. And for a time, and people will go for decades with amyloid in their brain, and their thinking is just fine. So as long as you've got a low level and you're able to coat and destroy these things and sequester them from your normal brain function, you can do well for very long. And that's a very positive response of your system. But if you have continued exposure or overwhelming exposure, now you have the next level where you now have inflammation. And that inflammation starts to damage the synapses. So you literally have a network insufficiency. You've got this amazing brain with 500 trillion synapses, and you start to pull back. You don't have the support. So we look at this as a supply and demand. When you've got lowering supply because of less blood flow, less oxygenation, less mitochondrial function, less insulin sensitivity, less ability to make ketones, all the things that support your brain. And now you've got more demand because you're dealing with toxins and pathogens and things like that. You can no longer maintain a 500 trillion synapse brain. What's happened is we have evolved to have these amazing neural subnetworks. We have one for neuroplasticity, it's like driving a Ferrari 240 miles an hour all the time. There's risk that it's going to break down because you can store more in your brain than over 2,000 home computers. So you have selected and selected and selected over the evolution for performance over durability. The organisms that selected durability were killed by the ones that selected for performance. So we have these incredible performing brains. And when you go, each of these now has an Achilles heel. When you fail on the neuroplasticity level, you get Alzheimer's. When you fail on the motor modulation and motor control level, you get Parkinson's. And when you fail on the power amplification system, you get ALS. So these systems are finely tuned, highly evolved, and they're not made for durability. So we've really got to take good care of them.
So it's really interesting. So what I'm hearing is it's a combination of these kind of onslaughts that are coming in, right? That the brain is defending itself to, in combination with your metabolic health status that
Yes.
kind of causes the storm, right? One of those may not in and of itself be enough, but if you're metabolically unhealthy, a little bit like we saw with COVID, then it can have a really deleterious outcome in the case of something like Alzheimer's. Is that how you would describe it?
This is a fantastic analogy because we see many parallels between COVID-19 and Alzheimer's disease. And as you know, now people are seeing, oh my gosh, COVID increases brain aging. It increases your risk for Alzheimer's disease. That's been shown by the epidemiology studies. And what happens with both of these is you have your innate immune system, the inflammatory piece is ratcheted up. But the adaptive system, the part that goes after the specific bacteria and specific viruses, et cetera, is not able to clear the problem. So you have this ongoing. So what happens? You die in COVID-19 of cytokine storm. So in other words, the virus actually has a mechanism to hide itself from your innate immune system. Your interferon is interfered with, so you have a decreased response. And so what happens is your body doesn't recognize it. Suddenly, finally, there's enough virus, and it now gets hyperactivated, and you die from cytokine storm. In Alzheimer's, you die from cytokine drizzle. Instead of being this massive storm the way it is in COVID, you have this ongoing mild production. It's a mildly inflammatory process for decades. And unfortunately, that leads to a loss of synapses over time and a literal downsizing of the network. So indeed, there are many parallels between COVID-19, especially long COVID, and Alzheimer's disease.
And it's really interesting. I mean, when we look at risk factors, right, there's a few that I think would come to mind. You and I were talking offline about ApoE4.
Yes.
There's also like some evidence, isn't there, around, I think, footballers having a higher risk. So if you're constantly heading a ball and destroying brain cells, there's concussion injury in addition to these things. What would you say, like, for someone who's listening to this, there's also this sort of nervousness, I think, for many women as they go through perimenopause, of feeling like my memory isn't quite the same. I walk into a meeting and I can't quite remember what I was going to say, or I walk into a room and I can't remember why I went in there. And there's this sort of temporary reorganization, if you like, of the brain as it goes through an upgrade, according to Dr. Lisa Mosconi. For someone, which is, that's really interesting. For someone who's listening to this, we're going to dive in, because in the book you go into this in tremendous detail, which is super helpful, into all the metabolic markers and vitamins and nutrients in a moment. But for someone who's listening to this, how would they distinguish, without that extra biomarker tracking, that they're getting symptoms like, am I at risk here? Do I need to be paying attention to this? How would they know early on? Because I know you say it's very treatable if you can get in early, but how would you know?
Yeah, preventable and reversible. And the later you wait, the harder it is. Of course, the earlier you start, the easier it is, and the more complete it is. So, it's very straightforward once you understand that this is about supply and demand for your neuroplasticity network. Anything you can now see, it's been so strange for years, like any low vitamin D, perimenopause, as you mentioned, being a footballer, ApoE4. There are dozens and dozens of these risk factors, and they're very disparate. Why would it be hormonal and vitamin related and insulin resistance, your diet related, your gut microbiome related? But if you understand that all of these things are contributing to that beautiful balance between supply and demand, and the big three things that impact that are energetics, so energetic support for your brain, inflammation, and toxicity. So anything that changes that balance. So as you said, when you get to perimenopause and your hormones are beginning to decline, you are losing some of that support for that network. And of course, there are estrogen receptors within the brain. Estradiol actually supports brain energy metabolism. So these things are critical. And you're right, as has been shown by a number of researchers, the PET scan changes you see in the brain at the time of menopause are strikingly similar to what you see in Alzheimer's disease. For most women, of course, you go through a period and then you're fine again. But for some, of course, there is a decline. And we're seeing this a lot. When I was training many, many years ago, we never saw people in their 40s and 50s with Alzheimer's. Now it's one of the most common things we see, and we see it very commonly associated with perimenopause or menopause. But you asked, how do you know the difference? And it's a great question, because even the PET scan is not showing a difference during that period. So what you really want to do is, for anyone who's 35 or over, get on active prevention. Optimize these basic things. And the great news, and this is in the book, you can see what your status is, where you're looking at your p-tau 217, GFAP, NFL, and A-beta 42. So that tells you your current status. Then you can look at, well, what's my risk? And you mentioned ApoE4, so there's a genetic risk, there's a metabolic risk, there's an inflammatory risk, there's a toxicity risk. You mentioned footballers, there's a traumatic risk. All of these things create some degree of risk. And so that really will give you insurance that you know where you stand and that you can optimize things. And this is why we've been saying Alzheimer's is optional. You don't, if you just get on early and get evaluated, get on active prevention or earliest treatment, you don't have to wait to get dementia. When you develop dementia from Alzheimer's, which is the most common cause of dementia, you actually go through 4 phases. So you have a long, long runway. You have a phase where you're asymptomatic. You can show changes already in spinal fluid and in the blood test that I mentioned. Then you go through a phase that's called SCI, subjective cognitive impairment, where you know that something's not quite right. You're not remembering things the way you used to, or you're not able to organize things the way you used to. But you're still able to score normally on cognitive testing. That is called SCI, and on average, it lasts 10 years. The SCI patients that we see do extremely well. And we have people now we've published who are doing great for more than a decade down the road. So, and actually the very first person that I treated successfully, which is back in 2012, is now just turned 80. She's walking across the U.S. She's been doing great. She's a brain health coach and has her own patients now, and is walking across the U.S. You can see her on, if you go to judywalks.org, you can
Julie
see
Walks,
her.
did you say?
Judy Walks, Judy Walks. You'll be able to see her walking across the country to bring attention to the fact that we don't have to wait for it. We don't have to do this. Now, the third phase, if you don't do something during the SCI phase, is called MCI, mild cognitive impairment. And by definition, what that means is you now are not scoring normally on your cognitive tests, but you can still take care of yourself. Your activities of daily living are intact. Each year, people with MCI, 5 to 10% of those people will convert to that fourth and final phase, which is called dementia. And by definition, then you're losing your activities of daily living. And as you indicated, ultimately you get to the point that you cannot care for yourself. Judy's mother actually went through and she watched her mother die of Alzheimer's, unfortunately, and not be able to recognize her. So when she was developing it, her doctor told her there was nothing to be done. This is back in 2012. Someone suggested she come to my laboratory. And so we started talking at that time. And so she's addressed the things that were driving her decline. And she's done very, very well for 13 years and counting. So to answer the point about perimenopause, because really I recognize I've never really answered your question. And that's because you can get some of the same sorts of things happening. You can have a problem with remembering. You can have a problem with organizing. But the difference is that it will be progressive. So I recommend if you do have that, don't wait. Get in and get evaluated. Look, if someone tells you, yes, you have no Alzheimer's disease, your biomarkers are good. They may even do an MRI and show you, yes, your MRI is normal. Then great. This idea that, well, you don't want to go in and have it not be Alzheimer's. No, that is what you want to do. You want to go in and get things early. And if you're not having Alzheimer's, fantastic. Too often, people will wait. Doctors will say, well, it's not that bad yet. Come back in a year. And they'll do that until they say, well, it is Alzheimer's. There's nothing we can do. Everything is upside down in this disease. They tell you don't check your genetics because there's nothing you can do about it. There's nothing you can do to prevent or reverse the problem. Don't bother getting evaluated. It's probably just normal aging. These are all antiquated approaches, which has led to so many people dying needlessly of this problem. So we would say the opposite. Assume that we are all at risk for cognitive decline because it is such a common problem, and get evaluated if you're 35 or over. Find out where you stand. We've trained over 2,000 physicians all over the world, including in the UK, in the US, and 8 other countries. So find out where you stand and get on active prevention or early treatment so you don't have to worry about this. The point of the book was to allow everybody to have a brain span that's as long as their lifespan. So whether you're going to live to 80, 90, 100, 110, 120, whatever it is that you're trying to live to, you don't want to spend those last years in a nursing home. So you want to keep sharp. If you've got some degree of cognitive change, you want to get in early and reverse that cognitive change and sustain the improvement over years.
When you look at someone, I love that, by the way, make the brain span as long as the lifespan. When you look at somebody who has Alzheimer's, there's obviously a very and you and I was mentioning to you earlier, I have personal experience of it with my mum. It's quite an emotional thing for those people around the individual. What about the person themselves when they're going through it? In the early stages, they're aware that my brain's not quite working as it used to. I'm curious, when you say they die with Alzheimer's, what happens there, like,
Yeah.
and how aware that individual is, because increasingly they're having less and less cognitive function, right? So is it that actually the kind of flight path on the way out for them is maybe gentler than it is for those around them? You would hope so. I don't know if
Yeah.
that's true in reality.
Yeah, that's such a good point. So Alzheimer's starts out as a personal disease and it ends up as a family and social disease because it now affects people at your work, all your family. It really just devastates families. It's really unfortunate. So again, this is why we recommend everyone get evaluated. So at the beginning, you're right. People have insight, but they keep on being reassured. Well, it's probably just normal aging. Well, don't worry about this. People used to say, if you forgot where your car is in a parking lot, don't worry about it. But if you forgot that you came in a car, then you should worry about it. Well, that's waiting far too long. So the
Mm.
early things that happen is people will notice they can't remember names the way they used to. They can't remember numbers. Sometimes it'll be that they have trouble calculating a tip, for example. They will have trouble balancing the checkbook. They'll drive up to a stop sign and realize that they don't really know. In a place that's familiar to them, they won't know which way to turn. So they'll have trouble navigating. They'll have trouble adding numbers in their head, things like that. They'll get a new device like an iPhone or something, and they'll have trouble learning a new device. And they'll have trouble organizing things and learning new information. These are all things that they recognize, and unfortunately, people will tell them. That this is just normal. No, that's the time. Jump in, find out, because there's so much you can do about it. Now, as you indicated, if they don't, they go through the SCI phase, they go through the MCI phase, and now they're getting into the dementia phase. You're absolutely right. They then begin to lose insight, and ultimately, they're not as aware of the problem. However, unfortunately, they are aware of the problem until a fairly late stage, and often for people, as you know, it is a feeling of desperation. They are depressed, understandably.
And lonely
They're
is what I've noticed, like with my mum, because her speech is so affected that
Yeah.
it's really caused that social isolation because she can't communicate. And I think that's really difficult, right, for the individual, because you start to feel cut off from people apart from your really close family and friends who have the patience and will, be with you.
That's a very good point. And there are, depending on the area of the brain, there are different areas of the brain that are affected. We generally think of Alzheimer's as affecting the temporal lobes and the parietal lobes. Those are the two main sites. We think about it within the temporal lobes as affecting the hippocampi. So you're losing the ability to make new memories. But what's interesting is, in a sense, this is a programmatic downsizing. Your brain is essentially responding by saying, okay, I can't do everything that I've done. So what can I live with? It's a little bit like if you've got to live with less, what do you want to give up? Well, you've got a tremendous amount of information that you have generated, that you have stored over the years. So you can live surprisingly well without learning new information. And people I
Mm.
see all the time, they're out playing tennis, they drive around, they can do their jobs, they can do their lives, but they can't learn new things very well. So they have sacrificed that piece of it. The other thing that happens is that in your brainstem you have something called the locus ceruleus, which literally means blue spot. And this is the thing that projects all of the norepinephrine, the noradrenaline, to your cortex. So this is the thing that's kind of your supercharger. And so that part starts to go down. So you lose, your brain is essentially saying, I'm not going to use that supercharger. I'm not going to use the extra fuel because I don't have a lot of fuel. And I'm going to work with what I have because I can do very well for a long period. And so that's actually a response that works very well for a lot of people for a long time. when you now begin, you can't even support that, is what you're describing, that then now you're losing the ability for your stored programs. But during this time, there are people that will have specific areas that are damaged. And as an example, there's something called posterior cortical atrophy, where you lose the ability to analyze visual information. And that represents about 5 or 10% of people with Alzheimer's disease. So it's frustrating because they can't see multiple objects in their field. They can't drive. They will crash into things like that. And then there's another one, which is called primary progressive aphasia, where they have trouble coming up with the right word. And just as you said, it's very frustrating. That can happen early in some people when they have this PPA, this primary progressive aphasia, where they have trouble with coming up with the right words. And so they'll get frustrated when they're trying to speak. So all of these things are things that are happening as you are downsizing and no longer able to support that 500 trillion synapse network. So what we are simply trying to do is identify in the people what's causing the problem. Is it a change in your oral microbiome? Is it a tick-borne illness? Is it a leaky gut? Is it, as you said, metabolic changes represent the most common, where you have a pro-inflammatory state due to things like insulin resistance and metabolic syndrome, so common. And so these things all contribute. And typically, when we see people with cognitive decline, they have multiple causes. So they'll often have ApoE4 and some metabolic disease with some inflammation and a pathogen, and whether it's herpes simplex or another one, and some toxin exposure. You've got to address all of those things. You are literally restoring that network function by increasing the supply and decreasing the demand. Then when you do that, now you have to rebuild what has been lost. But person after person after person, and we've published hundreds that have shown improvement. And it's not a surprise. It's you are changing the biochemistry of the synapses in the brain.
Yeah, so I guess if we talk about we'll talk about the healthy behaviors and the things that they can do to have an ageless brain, the title of your book. But first, if we pretend for a moment that we're going to engage in risky behaviors, what would be the most risky things? Would it be drinking lots of alcohol, having very short sleep, being sedentary? What would be, have you found, the most risky behaviors that contribute to the exposure?
Yeah, that's a great point. In the first book, The End of Alzheimer's, I wrote a chapter in there, how to give yourself Alzheimer's. So basically just saying, here are the riskiest things you can do. If you really want to drive your synapses into decline, then do a lot of the things. And I wrote that because so many of us are doing them already. That's a big issue. So if you really want to hurt yourself, what you want to do is address the basics. So you want to have a Western diet, so that you want to have a high carb, pro-inflammatory, low microbiome sustaining, low fiber diet, which spikes and troughs your glucose. This is why, by the way, CGMs, continuous glucose monitors, have been so helpful. People see both what they're eating that's getting their glucose to spike, but they'll also see that when they wake up at 4 a.m., it's because their glucose is 45. They've got hypoglycemia because they don't have a nice smooth curve, because they have a high simple carb diet. And I would add, the worst carbs are things like high fructose corn syrup. Fructose is actually more damaging than glucose, as Dr. Robert Lustig has shown, as Dr. From University of Colorado has shown, Rick Johnson, and others. So that's the first thing, is a horrible diet is unfortunately, a bad influence and a horrible risk. The second thing is what you mentioned, so no exercise. You need the blood flow, you need the mitochondrial function, you need the oxygenation. So that's risky behavior, sitting around doing nothing, getting a belly that's associated with insulin resistance. That's telling you, that's not good for your brain. And then another thing that comes along with those two often and is another risk factor for cognitive decline, is sleep apnea. And at least in the US, 80% of sleep apnea goes undiagnosed. So, and it's a common risk factor for cognitive decline. So again, with wearables, you can check. So each morning you can check and say, okay, how did I do? You want to have at least 7 hours of sleep. You want to have at least an hour and a half of REM sleep. You want to have at least an hour of deep sleep, and you want to have at least an oxygen concentration of 94%. So all those parameters will help you, telling you, yes, your brain is doing well while you're sleeping at night. And for so many of us, it's not doing well. We've got some sleep apnea. We've got low oxygen concentration. We've got poor REM. We've got poor time in deep sleep. So that's another way to give yourself this problem. So anything that you do to impact your optimal sleep is a huge issue. And then stress. As a neuroscientist and neurologist, I used to never think that stress was a big deal. It turns out I was wrong. It turns out that it's a very important thing. Now, humans are very good at dealing with acute stress and then resolution, and acute stress and resolution. That's okay. We're meant to deal with that evolutionarily. But we are not dealing well with chronic, unremitting stress. When you've got stress every day and you're always in that sympathetic drive, that's bad for your heart. That's bad for your brain, unfortunately. It's bad for your gut as well. So you want to give yourself Alzheimer's. That's a risky behavior, is ongoing stress. And then brain stimulation. A modest amount of brain stimulation is helpful. And when I say modest, I'm talking about reading books, doing Sudoku, doing brain training. Brain training has been quite successful. Brain HQ, a group that started this a number of years ago and really pioneered this area, is coming out with a beautiful study showing changes that they can actually see in the PET scan associated with specific programs of brain training. So that's very helpful. And then people are using things like photobiomodulation, so-called light therapy, that actually does support your mitochondrial function. So stimulation, you don't want to go crazy. So in other words, you don't want to stay up all night studying. That's not good for you. But you want to have some stimulation so that you have support for your brain. You increase your brain-derived neurotrophic factor, which is an important support for your brain. And then exposure to toxins, and these come in three groups. So it's the inorganics. You want to have a brain degeneration, live in a high place of high air pollution. Studies out of Mexico City have shown people living in high air pollution. Also in LA have shown people living in high air pollution, much higher risk for cognitive decline.
Do we see that more in places like India, for example, where air pollution is really high?
Absolutely. So where pollution is high, cognition is low, unfortunately. And here in California, the fires that we are exposed to, unfortunately, have these small particles that are associated. Now, interestingly, we've now all got to think about microplastics, something that's turned out that are concentrated in the brain more than the liver, more than the kidney. And it's not clear yet whether it's causal, but the epidemiological studies have shown there's definitely an association between high microplastics and increased risk for cognitive decline. Which one's causing the other, or is it both, that they're both feeding on each other? Not clear yet. So that's another big issue. Eat a bunch of plastic, be exposed to a lot of plastics, not good for you. And then, as I mentioned, there's air pollution and the inorganics. Then there's the organics, things like glyphosate, toluene, benzene, all these sorts of things. And then finally, there are biotoxins, things like mycotoxins. By the way, I saw a very interesting study just yesterday from Dr. Heather Sanderson, in which she's looking at before and after cosmetology. Basically, you're getting some cosmetics, in this particular case, hair coloring. And what she was showing is this dramatic increase in some of these dyes and things, and some of these toxins for your brain with hair coloring. So, again, be careful. We should all be thinking about some, regular detoxing just to keep these toxins to a level, because unfortunately we are exposed to them through our air pollution, through mercury amalgams, through the fires, through all these various things. And people have said, oh, the mold in your house doesn't matter. Well, some molds produce neurotoxic species. These mycotoxins do get into your brain. They do impact you. And we see it all the time as a common contributor to cognitive decline. So to some extent, keeping your brain healthy is keeping your entire body healthy.
Mm. Yeah, when you're looking at optimizing all these things, which actually you talk a lot in detail in the book about how to optimize the health of your mitochondria, how to keep inflammation low, how to keep your metabolic health in check. You talk about a state of mild ketosis. What do you mean by mild ketosis?
Yeah, great point. So for many of us who are eating a standard Western diet, we are insulin sensitive. Your brain only has two things. Your brain is like a hybrid car, which has two ways it can be fueled, right? Your brain is the same. It has two ways it can be fueled. It can be fueled by glucose. It can be fueled by ketones. And normally you go back and forth seamlessly. So that's called metabolic flexibility. So you go and you glucose. Now you are fasting. You're sleeping. You're not eating. Now your glucose is going down. Your ketones are popping in. No problem. You've got plenty of fuel. You go back and forth. For so many of us, after the age of 35 or 40, we lose both of those. So literally, your brain is sputtering. You've lost the ability to utilize glucose optimally because you have developed insulin resistance. And you can actually see the signaling in the brain that changes because it's reflected in the blood as you develop this insulin resistance. And so now your insulin starts to go up because you're resistant to insulin. You've got to make more and more of it. And what happens when your insulin is high, you cannot make the ketones. These are normally your liver's way of responding to not enough energy. It produces ketones, which are a way to ship energy from the liver to other places in the body, such as the brain. So now your brain is literally sputtering. So when I see people who are undergoing cognitive decline, this is an emergency. I need to get them back to being insulin sensitive. I need to get them back to being able to generate ketones. And often, Dr. Mary Newport, of course, has shown that just giving some exogenous ketones at the beginning can be helpful as they slowly get back to that metabolic flexibility. So this is a critical piece to be able to supply that energy, and losing that energy is so common and is one of the major contributory factors to cognitive decline. Literally, your brain does not have the energy to function normally.
Yeah, such a good point. And I think so many people, right, are not insulin sensitive, particularly in the UK and in the US.
Absolutely.
When you look at like brain energetics, which you've mentioned, I know in the book you talk about creatine. I've seen big benefits from taking creatine with I think just the cognitive focus. I also see really big benefits with resistance training, like on big muscle groups. So like compound lifts, squats, deadlifts, that type of thing. And also, and I see immediate benefits to that. If I've got a cognitively demanding day, chances are I will pick a physically demanding workout to precede it. Is that something that's producing long-term effects when we're producing things like BDNF or increasing that you can increase nerve growth factor, can't you, through other kind of supplements and things? Or are they sort of shorter term and it's just the importance of keeping those things up?
Both. So you do have short-term benefits and long-term benefits. And, I would mention a study that was published recently where they were looking at a short-term benefit of exercise for your memory. And the surprise was this was in 18 to 25-year-olds, and they could already see a difference in memory with those who were ApoE4 positive, even in that early time. So even though you don't get Alzheimer's till much later, it just tells us we should all be optimizing, doing exactly what you're doing there, because the armamentarium is huge. Exercise. In fact, regular exercise has been shown to have the same magnitude to decrease risk as a single copy of ApoE4 has to increase risk. So you literally can negate the risk of one copy of ApoE4 through regular exercise. which is fantastic. Now, as you mentioned, you get different benefits from different types of exercise. So you mentioned the core and the strength. The strength training is particularly good for insulin sensitivity, improves your insulin sensitivity, whereas the aerobics, particularly good for oxygenation, for blood flow. And so these things really work together and very well. I happen to like something called EWOT, exercise with oxygen therapy, because especially for us older folk, and I'm now in my mid 70s, so now it helps you to get blood flow and to get oxygenation. And so particularly good one. There are also these resistance bands, so-called Katsu bands, where people will get more bang for their buck. Basically, they are producing some resistance, so you can't exercise as much, but for the amount of exercise you do, you get more support. You mentioned the BDNF. You actually increase your ketone level, you increase your brain-derived neurotrophic factor level, and that does change your synapses. The brain training that I mentioned actually changes your cholinergic tone in your brain. So these are both short-term benefits and long-term benefits. And some of the brain training studies have shown just brain training gave a reduction 10 years later in the likelihood of cognitive decline. So I think the most important thing for everyone to realize is that we've been told in the past that there is nothing that can be done about cognitive decline. What it's turned out is the opposite. The armamentarium is huge, and it does have to do with exercise, and it does have to do with your nutrition, and it does have to do with your brain stimulation, your stress levels, your sleep ability. And there are supplements that can be helpful. People keep saying, well, supplements aren't a cure for Alzheimer's. Well, that's a silly statement. Nobody's saying that they're a cure for Alzheimer's. What we're saying is that they can reduce your risk, and getting the right ones to address the right things can be very helpful. And actually, the best study on a part of this was done in the UK, where it was shown that people who had high homocysteine, which is associated with poor methylation, were at increased risk for atrophy of the brain. And simply reducing their homocysteine with methylated B vitamins, and actually in this case they used B12, B6, and folate, and they showed that just doing that stopped that brain atrophy. So there are so many things that we can do. And this is, again, why if you can look and see what are the things that are your risk factors, what are the things that are driving any change you may be experiencing. Get in early, don't wait, and there is so much that can be done very successfully.
What's the best way that you would recommend for someone to access your book? So at the back, there's some very helpful tables that go through actually a lot of the supplements, a lot of the testing. Would you recommend that they work their way through this in order, that they test certain areas and then they look at supplementation for those areas that require support? When you were writing it, how would you like someone to best access it as a resource?
Yeah, that's a great point, and I'm glad you asked that. So I would recommend that people actually read the last chapter first. Look at, just to get, and you don't read it in depth. Take a look, get a general idea. The last chapter is about putting everything together. This is what's possible. This is why we should all have brain spans that equal our lifespans, whatever our lifespans are going to be. We should not be spending time in a nursing facility. And you'll see in the last chapter, as you mentioned, the charts that go through the different things that are evaluated. Just get an idea. Okay, then there I give two examples, and these are examples simply of what's possible. That there have been now over 10,000 patients on the protocol. Our ongoing clinical trial has clearly statistically significant differences, so they're doing very well on that. But these are just examples of people from young to old, what's possible currently. So that they, in both cases, so one is a person who gets one thing caught early. I won't mention what it is, a common problem with the brain. Another one is a different common problem with the brain. And just showing that catching it early, there's so much that can be done, so much that can be evaluated and treated. Then I would go to the beginning, because the beginning lays out, here's why we're doing what we're doing. the whole point of this is to combine performance with protection. What happens is people will think about one or the other. And so, if you're young, you say, I can do Adderall and get better performance, or I can do cocaine and get better performance. Yes, for a short period of time, but in long term, you're not getting the protection. You can get protection by putting your brain in liquid nitrogen, but that's not going to give you good performance. So what we want is the best of performance with the best of protection. And that is to combine these things to know what is optimal for each. And that's what the book is all about.
It's a really, really, really comprehensive guide. When we look at sleep, does sleep positioning, you mentioned duration. I guess there's two questions there. Maybe sleep's positioning, whether the brain, like the cerebral spinal fluid and the way that it kind of cleanses the brain, whether there's any positioning I'm curious about, but also whether there are people who, like, I tend to be quite an efficient sleeper, for example, and I'll just naturally wake up after 6.5 hours. I hit the metrics that you're talking about, but for me, it's like hard to stay in bed for 7 hours. Does everyone have to? We hear sleep scientists talk a lot about 7 to 8 hours. What's your experience on those two things?
You're absolutely right. There are people, and I would, before I go on, I would mention one thing quickly. There, we had one person who criticized and said, "Oh, you're talking about things like sleeping and eating." It's like, we all know this. Well, so in the book, I would mention we go into the new things: peptides, stem cells, bioidentical hormones, all the things that are people are doing that seem to be helpful, that are critical. GLP-1s, talk about all that sort of stuff, but these things work best, if you're going to do them at all, on the basics. So the basics are where people are failing. That's where people are not doing the right things and not getting sleep. Now, there's some beautiful work published on sleep. You're absolutely right about that, showing that not everybody needs 7 hours. For most of us, we do better with 7 to 8 hours of sleep a night. But you're right. There are the people. Look, if you're hitting your REM and your oxygenation and your deep sleep, and you're waking up normally and feeling refreshed after 6.5 hours, then that's what you need. 6.5 hours is good enough for you. It is a minority of the population that is that way, but it's been studied, and you're absolutely right. There is the group that only needs less than 7 hours of sleep.
And you see that on DNA tests, don't you? It came up on my genetic test that I had a lower sleep need, which was interesting. And I was like, oh, that sort of confirms it.
Yeah.
I think the risk comes, though, nobody has a sleep need of below 5 hours, right? That is genuinely detrimental to your health.
Right. And patient zero, the one who's now walking across the country, had a number of things that were creating her decline back in 2012 when I saw her. And one of them was she was working for the U.S. government and being sent overseas frequently, disrupting her sleep patterns. And she was typically getting 4 to 5 hours of sleep per night. And no surprise, that was one of the factors that was creating her decline. So she then started going about optimizing these various things. And she's done great, now 13 years later, still doing great.
That's so reassuring. You know what's really interesting, actually? I've seen that with, I don't know if you've come across a test that is a marker for inflammation called, by a company called Glycan Age, where they look at the glycans.
Absolutely. So there are a number of ways to look at this, and people have looked at tumor necrosis factor, and they've looked at, as you said, Glycan Age, the so-called advanced glycation end products, things like that. Of course, looking at your epigenome is another way to go. The standard way is HSCRP. All these things, these markers are very helpful to determine where you stand. You really can now get such a good look at people. We was just in a group yesterday of physicians that meets each week to go over the various cases, a little bit like a tumor board, but this is a cognition board. And with advanced imaging, with the genome, with all the different parameters biochemically that you can look at, the so-called genome and phenome, you get such a good look. So there was a person yesterday, for example, 65 years old woman with a strong family history of Alzheimer's, with minimal symptoms, just saying, am I headed for this? Is there a problem? Turns out her studies were excellent. So she, now we have a very good look at where she stands. She is doing great. We'll look again in a few years and see where things stand. But again, this gives us, we have a much better look a much better hold on things and a much better ability to make sure that virtually nobody develops this problem. It's so different than the old idea of I've waited and waited. My doctor told me I was just getting a little. Now I can't remember where anything is. I'm having trouble remembering, all the things in my life. I mean, that's the old-fashioned way of doing things.
When you look at stress, before we sort of close, that was
Yeah.
interesting to me because stress, I think, is endemic in our society at the moment. Everyone has a lot of stress. I noticed as well that the markers that you put for heart rate variability, for some of the individuals that I deal with who particularly have like very busy careers and family lives and things like that, those would be aspirational in terms of them meeting that. But when you look at HRV in the scientific literature, it's quite interesting, I find, how you see this sort of decline with aging.
Yes.
But then those individuals that get into their sort of 80s and 90s, their HRV is higher, which suggests that actually it's the people with the HRV, the higher HRV, that live the longest, I think, as opposed to it suddenly having a boost.
Yeah.
What would you say there? Like, how much do we need to? Because then what we don't want to cause is, right, any kind of nervousness around people
Yeah.
that they're not like managing their stress, because some of this is genetic, right? Some is lifestyle, some is aging when we look at heart rate variability. Would you say that focusing on that alongside like the deep sleep and REM is a really important metric for people to understand, actually, you know what, maybe I'm loading my system much more than I should be? And do we want to kind of edge up into more sort of elite categories?
Yeah, well, again, this is, there's a fundamental change. People will say to me all the time, I don't want to know my ApoE status because there's nothing I can do about it. No, there's a lot you can do about it. I don't want to check my HRV because I don't know how to make it better. And I'm worried about it. And we need to change fundamentally to say, isn't it amazing? We now, for the first time in history, have the armamentarium to make this problem go away largely. And again, this is what the book is about. There is so much that can be done. So don't worry about finding these things out. Find out if you're ApoE4 positive. Find out if you've got a high ongoing inflammation. Find out if your HSCRP is low. I've looked at mine and looked at the impact. Once you are tracking it, which is easy to do. Anyway, these wearables are very, very helpful, whether you like, Oura Ring or Apple Watch or Garmin or Fitbit, whatever it is that you like, you can now look and see. So you can increase it. In our trial, one of the things that we're including is increasing your HRV through different approaches. So you can do it with biofeedback. There's something called heart math as an example, which is a common one. You can do it with just deep breathing. You can do it with meditation. You can do it with yoga. You can do it with so-called forest bathing, Shinrin Yoku, which is a Japanese approach that so many people like. You can do it with nice music, relaxation. We weren't made to be going sympathetic drive 24/7. And we're just, we're recognizing that. Again, as a scientist working in the lab for all those years, I never thought any of this was, this was silly stuff. What do you mean yoga? That's nothing. Come on. And turned out, this actually does help. And there's, of course, all sorts of publications now on things like transcendental meditation, improving, improving your HRV, improving your blood pressure, improving your neuroplasticity, all these sorts of things. So, all of these things that are critical. So, whatever it is you like, check your HRV, and yeah, try to improve your HRV. I notice a difference. Well, mine will be, I can drive it from, it can be 15 or 20 and drive it to 100 with some deep breathing. So, over time, it's telling you your body is currently, you've got the pedal on the accelerator. Ease off a little occasionally and let your body relax, because you'll do better and you'll have better cognition, you'll live longer, all those sorts of things. You'll have less heart disease, of course, if you've got less of that sympathetic drive all the time.
100%. I use it a lot in my programs. We use a device that measures it on a 24 kind of hour basis, if you like. And people can see, oh, I'm moving into the green light. This is
Yeah,
what
yeah.
helps me, which is lovely, right? Because then they can do it. Amazing. Is there anything that I haven't asked you that I should have asked you, Dale? Have we missed anything here? I mean, I would invite people to go and pick up the Ageless Brain because I think it's amazing. I think even just from a longevity perspective, overall, everything is in here that you need really to optimize for that, all the testing, all the biomarkers, everything to look at. But is there anything that I should have asked you, I haven't asked you, that you think would be relevant for our audience?
Yeah, I think you've really covered it beautifully. I think, we haven't talked about the GLP-1 story
Yes, we haven't.
and
I
the
would
whole
like to,
thing with
actually.
semaglutide and, all these Ozempic, Mounjaro, Wegovy, Zepbound, all these sorts of things, tirzepatide, all the things, the new things that are going to be coming along. Of course, there's great interest right now. Is this going to be the Alzheimer drug? Is this going to be the anti-amyloid antibody approach? Has not worked well. It does not improve cognition. It often leads to brain bleeding. And I would say one caution. There is a published report showing that people who went on those antibodies and were ApoE44, specifically that group, and that's 7 million Americans, that particular group. It's about 2.5% or 2.25% of the population, but it's about 10 to 15% of the people with cognitive decline because it is such a risk factor. They did worse than the control. In other words, in that case, the drug made them worse, not better. So it should not be recommended for that group, and yet it is recommended all the time without recognizing that paper, which is an important analysis. So please be careful. I've got people coming to me all the time saying that they went to a university center, they were ApoE44, and they were told to use this anti-amyloid antibody without saying, hey, wait a minute, this paper shows that that's actually worse for you than nothing. So I would say be careful about that. Now, people are now migrating, saying, okay, it's always, what's the silver bullet? And we argue that it's not a silver bullet, it's silver buckshot. You need to hit the various things that are driving this. But GLP-1s are interesting, and we'll see what happens over time. They do increase your endogenous insulin. And they can help you to become more insulin sensitive. I'm wondering whether it's possible in the long run, we may see that just a couple of months of them to get you more insulin sensitive and then getting off them before you have long-term chronic problems. We don't know the chronic effects of these. They haven't been around long enough. Just recently, we had a person who clearly got worse on them, not better. So the story is not complete yet on the GLP-1s. And so, be careful. For some people, they may be helpful. For some, they may not be helpful. So I would just say, be careful. If you can become insulin sensitive without going on them, you're going to do yourself a favor, likely in the long run.
So you found that someone became less insulin sensitive after taking it?
No, they became more cognitively
More
compromised.
cognitively impaired.
So they actually, what they found was that once they started them, things clearly went downhill instead of uphill. Of course, the hope in the trials is that people will actually do better on these. We'll see.
Yeah. So that's really a spot to watch, isn't it, in relation to GLP-1s?
Absolutely.
Yeah, they're so controversial at the moment in terms of the benefits versus the downsides. And I think definitely not enough people, my understanding is they're not getting coached on how to really support their muscle mass at the same time as they're losing all this weight. And that would take care of insulin sensitivity better if they were doing it.
Exactly.
Yeah. Amazing. And I know you go into that in the book. We will link to the book. It's available in all bookstores. It's on Amazon. Clearly, this is a really a moving area, right? It's moving quite quickly. Mm-hmm. What is the best way for people to connect with you, keep up with you? I know you're super busy, but to hear about the research you're doing, what's new, what can you share?
Yeah, it's a great point. And, there is a lot of progress right now. Brain health, as you had mentioned earlier, brain health is important to all of us and something that we should be aware of. And thankfully, there are new treatments, the new blood tests. Those alone really fantastic to tell us what we've not been able to get before from blood tests. So this is a great area, and you can go. There's Facebook, Dr. Dale Bredesen, Instagram, X, Blue Sky. There is a wonderful documentary out on Amazon Prime that's called Memories for Life, Reversing Alzheimer's. Michael Bublé does a great job. The famous singer does a great job of narrating that. And it's about these people who have reversed their decline and how well they're doing. In fact, patient zero, who is now walking across the country, Judy, is in the documentary as well. So that's another way to get information. And then you can look at the clinical trials and the publications. We've published over 230 papers over the years. Many of them are freely available online. Some in the Journal of Alzheimer's Disease, some in a journal called Aging. So all this stuff is freely available online.
It's amazing. Thank you so much. And thank you for all the work that you're doing. I think just to like envisioning a world without Alzheimer's would just be such an incredible step for humanity. And you're making such a huge difference. I'm just super grateful to everything that you're doing.
Thank you. It's time for all of us to work together to reduce the global burden of dementia, and we have the tools to do it now.
We do. As you show by this book, it's amazing. Thank you so much, Dale. It's been wonderful to have you back. Really appreciate you.
Thanks so much, Angela. Stay well.